once again, I would like to thank you for participating to our meeting. And it is now the time for me to welcome the honor and to introduce you Dr. Christian Diehl. Good morning, Christian. Good morning, Doctor.
Thank you so much, Stefan, for your introduction. And good evening, everybody. I am very pleased to be with you. And as Stefan was telling, really, we regret about the situation and not being able to be face-to-face with you, as we did many times. But at least this technological possibility permits to have some contact, some relationship with you. And I thank you very much for your assistance, and we'll try to have a good time, you know, with tranexamic acid. And as the title is telling, it's an old molecule, but it has now a new life in dermatology. You know that tranexamic acid was discovered in 1962. It's quite old time, and widely used in the meantime to treat or prevent excess blood loss, hemorrhagia, you know, whatever the cause of them, major trauma, postpartum, surgery, tooth removal, nosebleeds, any cause of hemorrhagia may be treated with tranexamic acid. We have usually two forms, two galenical forms, tablet, which is oral form, obviously, but also intravenous injection for emergency situations. Chemically speaking, tranexamic acid is a very simple molecule. It's a synthetic derivative of amino acid lysine, and this is a small molecule, and for this reason, we can use it topically in dermatology because it's able to penetrate the skin barrier. The first mention of tranexamic acid in dermatology was in 1979, and a Mexican colleague was reporting a very good result by using tranexamic acid in actinic prurigo. And after that, 20 years of silence, you know, since 1998, Maeda, a Japanese investigator, demonstrated the activity in vitro of tranexamic acid as blocking melanogenesis. This was the next step, and focusing on melanogenesis, on hyperpigmentations. And after 10 years of silence again, and in 2010, the publications about tranexamic acid in dermatological indications are more and more frequent. And first, oral use of tranexamic acid in melasma. This was the first publications, you know, and the most ancient ones, using oral tranexamic acid, always in the same dose of 500 milligrams per day, 250 in the morning, 250 in the evening, during 3 months. The protocol of oral tranexamic acid in melasma is very well established, and nobody did it on another way, you know. So I think if we want to follow this protocol, we are pretty sure of getting very good results in melasma. You can see in this case, it's Nepalese patients, it's a Kathmandu study, and always 90 days. And the next one was a study in Indian patients, and still with very good results. And you can see still with the same protocol of 90 days and 500 milligrams per day. Chinese patients and Korean patients, you see that same type of results, Pakistani patient, and always the same protocol and the same duration of treatment. But there was a very early, there was a concern of dermatologists about possible systemic side effects of tranexamic acid. It's not very frequent, you know. We must not emphasize about this and dramatize and so on. But the problem is that when systemic side effect is occurring, it's very severe one usually. We are talking about possible pulmonary embolism, deep vein thrombosis, myocardial or cerebrovascular infections, uterine thrombosis, acute renal phenomenon, seizures, really severe side effects. And most of dermatologists now don't want to take the risk of using systemic tranexamic acid and prefer topical tranexamic acid, mainly in melasma. And we are focusing first on melasma because this is the most important indication, and for me the most valuable indication of tranexamic acid in dermatology. And contrarily to systemic treatment, there is no fixed protocol, you know, because some investigators tested 2% tranexamic acid, other ones 3%, other 5%, and you'll see that the protocol of use is different. It can be as a classical topical product, you know, as a cream, but it can also be as microneedling, or after we'll see more sophisticated uses of tranexamic acid. In this case, it's a Korean study. We have good results with 2% tranexamic acid twice a day, 3 months. And I must tell you, according to my experience, that after 4 weeks, after 1 month, you have already some result. But the optimal result, you can get it in melasma after 3 months. This is an interesting study, you know, because it was the only one in South America. And you see this one is 3% tranexamic acid, still 90 days, and good result also. And the good thing in this picture is something we shall resume later, is the vascular component of melasma. You know, melasma, when I studied dermatology, everybody was telling it's a disorder of pigmentation. But now we are much more complete, and we are teaching our students it's not only a disorder of pigmentation, but also a disorder of vasculature, a vascular disorder. And so you can see 3% tranexamic acid in Irani patients, good result after 90 days. This is a little different protocol, you know, with one side of the face with only IPL, and the other side with IPL plus 2% tranexamic acid. And you see that the result on the combination face is much better than on the side with only IPL. And so this is a good idea for you. You know, if you are used to make IPL sessions to your patients, you can improve a lot your results with combination of topical tranexamic acid twice a day in the meantime, between the sessions. There were also good associations between topical tranexamic acid and topical niacinamide, you know, vitamin B3. And in this case, 2% niacinamide, 2% tranexamic acid twice a day, 2 months, and very good results on Asian skins. You know that melasma is a common cause of facial hyperpigmentation. It's affecting millions of individuals worldwide. 90% are women, 10% are men, approximately. We know that sun exposure, oral contraceptives, pregnancy may exacerbate melasma. It's very well known. And the treatment, the common treatment is including topical depigmenting agents, mainly hydroquinone, chemical peelings, laser, and energy devices. And this is very important for you because most of your people, of your patients are phototype 3 or 4 in Middle East and the GCC area. And these phototypes 3 and 4 are the most prone for melasma. You know, in these people in Western Europe, in the States, with phototype 1 or 2 very fair skin, there is less risk. But the highest risk is in middle phototypes, you know, in medium phototypes 3 and 4. And when we are going to 5, it's the risk is a little less, and phototype 6 has not very frequent melasma. The main causes are classically genetic factors. You know that we have complete families with history of melasma, from the grandmother to the girl to the daughter. And besides genetic factors, sun exposure is a very important matter, you know, and we must, of course, avoid it in this case. And as we told it, a role of female hormones. But more recently, we discovered other factors in the pathogenesis of melasma, and these are dermal factors, you know. These are factors related with dermal cells. And first, mast cells, you know that they are able of releasing histamine, and histamine, of course, is stimulating melanogenesis. And in fact, in the reality, there is an increase in the number of mast cells in lesions of melasma. And this must be highlighted, you know, and if there is higher number of cells, there will be higher release of histamine, and melanogenesis is activated, is stimulated. And there is also, I told you, a potential role of dermal vasculature, which is damaged. There is an increase in the number, in the size, in density of blood vessels in lesions of melasma. And also, maybe this is the primary cause, an increase of vascular endothelial growth factor, which is stimulating and provoking neovascularization at the level of the lesions. And you see, finally, of course, melanocyte is the center of interest because this is the one which is producing melanin and producing hyperpigmentation. But many cells are in relationship with melanocytes and influencing melanocytes. First, keratinocytes. You know that there is a very strong crosstalk between melanocyte, keratinocyte, and if there is no presence of keratinocyte, melanocytes will not produce melanin. There is a necessary presence of keratinocytes, and they are influencing melanogenesis with different factors, you know, like endothelin 1, like basic fibroblast growth factor. And this is the same thing from endothelial cells. We talked about this neovascularization, and endothelial cells are releasing endothelin 1, which is impacting the melanocytes. From the fibroblasts, we talk about stem cell factor, which is also upregulating melanogenesis, as histamine is doing it when released by mast cells. So there is a multifactorial, multicellular influence of the melanocyte, and we must act at these levels. You know, when we are prescribing hydroquinone, we are only working at this level, but it must be much more extensive, you know, and much wider. Tranexamic acid is down-regulating the activity of mast cells and consequently the release of histamine, is also directly inhibiting melanogenesis by suppression of pro-hormone convertase and alpha melanocyte stimulating hormone. And this is the mechanism of action on the melanocyte itself, tranexamic acid, and this is its mechanism of action, you know, in hemorrhage. It's inhibiting transformation from plasminogen activator to plasmin. And then, in the case of melanocyte, it will avoid all these releases of alpha MSH, of fibroblast growth factor, of arachidonic acid, which are impacting melanocytes and stimulating melanogenesis. Tranexamic acid is also able to reduce the number of blood vessels in dermis, inhibit neovascularization, and this is of importance on melasma, and reducing the levels of vascular endothelial growth factor by downregulation of the activity of mast cells. And finally, you see that with tranexamic acid, we are working on all this, first on melanocyte, of course, we told it directly, but also on the other cells and down-regulating the impact of these dermal cells, especially, and keratinocytes also, on melanocyte for upgrading melanogenesis. Now about toxicity, because we must take into account toxicity of our drugs, of course, and you see that acute toxicity of tranexamic acid is very safe. You see, there is a need for very high doses of tranexamic acid if we want to reach toxicity levels. And for instance, if we talk about an adult of 60 kilos weight, we need 600 grams of tranexamic acid. You know, it's a huge quantity, and then we are reaching DL50. But really, there is a very good toxicological safety, and the same, you know, in case of repeated doses. There is absolutely no risk about it. And very important, tranexamic acid is not teratogenic, and this permits, you know, to gynecologists to use it in blood loss during pregnancy or during delivery, but also to the dermatologists to use it in melasma during pregnancy. We cannot use hydroquinone because it's toxic, it's teratogenic, but yes, we can use tranexamic acid during pregnancy and breastfeeding also. And of course, no genetic toxicity and no carcinogenicity. Really, tranexamic acid is very safe, and this is good news for us. And I told you that there are more sophisticated ways to use tranexamic acid in melasma, and the first one is microneedling. And you see that with dermaroller plus 0.5% tranexamic acid once a week, we have very good result. And once more, you see, 90 days, 3 months. In this case, there was double-blind, not double-blind, but let's say comparative study between the left side of the face using derma and 10% tranexamic acid, and on the right face only derma. Of course, derma is not a good treatment, you know, for melasma, and you see that there is no much effect. But on the side with combination treatment, derma microneedling and tranexamic acid, the result is excellent. Well, it's the same study, you see, with very good result with combination and poor result using only derma. Now there is another way. It's intradermal injection of tranexamic acid. And you see in this study, for example, there was a comparison of oral systemic tranexamic acid and 0.4% intradermal tranexamic acid once per month only during 3 months. And you see that both protocols are giving the same result. And in the case of intradermal, without any risk of systemic side effect, of course. And you see that the results are similar after 3 months. These are pictures from this clinical study, and we can see obviously the results, and more in this patient. You know, this is 1 month and 3 months. Well, another protocol, always interesting, you know, for us, comparing the activity of a new product to hydroquinone, because we know very well hydroquinone, we use it very often, and it's interesting having a comparative study. In this case, on one side of the face was applied 2% tranexamic acid, and on the other side, 2% hydroquinone. And you see which is the most efficient in terms of reduction of the level of melanin. This is tranexamic acid 2%. Tranexamic acid 2% is more potent, is more efficient than hydroquinone 2%. And we can observe it here. We have on one face hydroquinone, on the other one tranexamic acid. You see that the difference is important, and another patient here too. And you can refer to this paper. It's a recent paper in 2018. And now we must tell that after the silence in the use of tranexamic acid during many years, now every month we have new papers, new studies, new trials, and really there is important supporting literature for using tranexamic acid in dermatology. Another comparative study between intradermal 0.4% tranexamic acid and the same tranexamic acid 1% and hydroquinone 4%. And you see that the most potent products for reaching decrease of MASI score of the level of melanin are first tranexamic acid 1% intradermal injection, and also hydroquinone 4%. You see the efficacy of both is very similar. Here we have examples. You see that obviously tranexamic acid 1% in intradermal injections is doing better than hydroquinone 4%. Well, different trial between intradermal 10% tranexamic acid plus hydroquinone 4% versus hydroquinone 4% alone. And you see that the combination is much more efficient, you know. And when we are adding tranexamic acid to hydroquinone treatment, we are getting better result. And this is a general result, you know, not only in this study, but in any published study. And if you do it in your practice, you will see that we have improved result, improved efficacy when we are combining tranexamic acid with hydroquinone. And here we have some pictures, of course, of this study. And now, topical tranexamic acid 5% versus hydroquinone 3%. And this was once per day and during 3 months. And you see that the result is the same. And we can compare tranexamic acid with hydroquinone in their topical applications, you know, in terms of results. But you see the difference. The difference was about side effect. With tranexamic acid, there is no side effect. With hydroquinone, and all of us, we know about this, we had 20% of side effects, you know, irritations or burning sensation or something like this. And in this case and in all cases, you know, tranexamic acid is much more comfortable for the patient than hydroquinone. Here we have the pictures, you know, demonstrating the efficacy of the product, especially of the combination. And now this was tranexamic acid oral plus topical 3%, and on the other side the same oral tranexamic acid and topical acelaic acid 20%. Then this is a comparison between tranexamic acid 3%, acelaic acid 20%, and which is the best result with tranexamic acid, once again, you know. And tranexamic acid 3% was shown to be more efficient in decrease of MASI score than acelaic acid 20%. Well, there is a repetition, you know, we already saw it. And now this is interesting because this is a combination of topical tranexamic acid 3% with laser. And most of you are using lasers in your practice. You are getting results, and very often good results. But you see what? You can improve your good results by using in combination topical tranexamic acid 3%. You see that MASI score in this case was reduced by laser alone, you know, of course, and much more with the combination of laser plus home use of tranexamic acid, of topical tranexamic acid. And this is a good way for you of improving the results you are obtaining with your in your practice with this kind of devices. And here you can see that the results were much better on the side of the face treated with combination than on the other side with laser alone. And now this is an interesting paper, but there is a warning, you know, because till now we talk about trials in melasma with large quantities of patients, you know, at least 30, 50 patients. But this paper was only about one case, you know, about this patient and nobody else. And it was shown that oral tranexamic acid was plus application of topical tranexamic acid were able to reduce post-inflammatory hyperpigmentation. We know how difficult it is of having good result, positive result on post-inflammatory hyperpigmentation. It looks in this case that it was doing well, but I must repeat you, I have no personal experience, and on the other side, this is only one case report, and we must maybe go ahead and testing this protocol in other patients in order to make sure about this. And of course, you are dizzy because there is a lot of data, you know, a lot of information, and we have to classify a little the information before prescribing, which is the best way, which is the safest one. We have to organize all this data. And I did it in a paper last year, and I reviewed the complete literature, you know, about tranexamic acid used in injections, almost 500 patients, oral use more than 1,000, and topical use of tranexamic acid 311, and this was in melasma in published studies, you know. So we have a good view. There is quite a good number of patients in total between these published trials, you know, and we can make an idea of which prescription is bringing best results and which is the safest one. And this is the result. You see, the best way of using tranexamic acid is intradermal injection, 0.4%, and 1 injection per month. It's a very simple protocol and very safe and very efficient. And with this protocol, you are getting almost 65% of reduction of MASI score. And the second one is topical 3% tranexamic acid twice a day, 56% of reduction. The third one is topical 2%, 49%. And it looks normal, you know, that topical 2% is weaker than topical 3%. But this one is not normal, you see, that with topical 5%, we have lesser result than 3% or 2%. And nobody can explain it, and nobody tried to do it, you know. But I think that with such high level of tranexamic acid, we have saturation of the sites, you know, where it's acting, and then we are losing activity. The best topical form of tranexamic acid is 3%. And you see that oral tranexamic acid is giving a little lesser result than topical forms and much higher level of risk level, you know, of side effects. And about which is the safest, injectable tranexamic acid, I mean intradermal tranexamic acid, you see that there is a very good acceptance. Only very slight side effects like pain at injection site or sometimes discomfort of the patient, but almost nothing. The same, you see, for topical tranexamic acid. Excellent tolerance by the patients, and really the patients are very happy and very comfortable and don't suffer any side effect. But in case of oral tranexamic acid, you can have some gastrointestinal discomfort in some studies, and especially very severe adverse effect in this case in this study, because it was deep vein thrombosis, and of course the treatment had to be discontinued very urgently. So topical or intradermal protocols are the safest ones, of course. And now we talked a lot about melasma, but there is a second interesting indication in rosacea, and especially because it's very simple. It's always a topical treatment, you know. In this case, 10% tranexamic acid solution was applied during 20 minutes on a gauze, you know, very simple way to do it, during 20 minutes on rosacea lesions, once per week, only once per week, and you see that the result is perfect after 1 month. 5 sessions, 1 month, you have perfect result, and especially this is very important on telangiectasia. You know that we have a lot of difficulties in improving and removing telangiectasia, and tranexamic acid looks to be very helpful in this way. You see the same protocol in the same clinical study with excellent results also. One more, and very simple, you know, very safe, very simple. And this is 3% tranexamic cream twice per day. And you see in this case also, in just 2 weeks' time, you can get excellent result. But of course, you must limit yourself, you know, to inflammatory rosacea. Because if we are talking about papulopustular, it makes no sense. And this is not a good solution, you know, only in erythema telangiectasic rosacea in inflammatory stage. And this is very interesting. You know, it was published 1 year ago, and this is post-acne erythema. And you know it very well, you know, it's very frequent. We are treating our patient, acne is cured, but you have this aftermath, you know, of post-acne erythema. And the patient is generally worried about this, of course. And you see that tranexamic acid, topical tranexamic acid, is a very good solution in this case. And this was only a case study, also a case report, but I had some experience with this, and really we are getting very good result. And in quite a short term, in 1 month, you can get good result, and you can have complete disappearance after 2 months. And now we kept this for the end of the presentation, presentation of TRANACIX, which is LSI SILDERMA product. It's a topical cream with 3% tranexamic acid, you know, ideal concentration. It also contains a broad spectrum photoprotection SPF 20. I don't want to tell you that this is enough, because in Middle East, in the GCC, sun radiation is very strong, but at least it's a minimal protection, you know, in order to make sure that the patient will not go outside without any protection. What we recommend are 2 applications per day on dry skin. And why? Because all literature data, you know, are collected with 2 applications per day. So let's not invent something new or so on. 2 per day is perfect. Efficacy is demonstrated in various published clinical trials. After 3-month treatment, we saw it extensively. It's very well tolerated, and I know that in the laboratories they don't receive any complaint about tolerance for this product, and this is online with the results of the clinical trials, you know, absence of side effect, and a tube of 30 grams. This means for melasma with 2 tubes, you can have the complete melasma treatment of 3 months. And the product is made in France according to usual GMP standards. So coming soon, and this is interesting, we told about the interest of mesotherapy or microneedling with tranexamic acid, but also in rosacea, you know, application of this solution. And in 2 months' time, the laboratory will launch TRANACIX in a sterile facial solution. And this will be vials, you know, with sterile solution of tranexamic acid, 10%. So you can use it as it is, but also use it with dilution. So thank you very much. I will give back the session to Stefan, so he will be able to check the questions and will be able to answer your questions. Thank you very much for your attention.
Thank you very much, Dr. Christian Diehl. Thank you very much for your time and for the nice presentation regarding the tranexamic acid and how to use it and why to prescribe such ingredients. In fact, we have some questions coming from the doctors listening to us and watching to the presentation. The first question is a double question coming from Dr. Alak Al-Ghurabi. The double question is, first, is it suitable for sensitive skin? First question. And the second one is, from which age can we use it?
For which? The second one, I didn't hear it very well.
The age when we can start using it.
Okay. So the first question, yes, doctor, you can use it on sensitive skin. And I think this is a very good indication of tranexamic acid because it's very safe, very well tolerated. And if you compare with products like hydroquinone, especially, you must, let's say, give a favor to tranexamic acid versus hydroquinone because there is a complete lack of side effect with tranexamic acid, with topical one. And the age, from the age of 15 years onward, you can use it. You saw that toxicity is very low, and we could even, I will tell you a stupidity, but we could even use it in babies, you know. But we don't do it, of course, because there is no rosacea and no melasma in babies. But really, it's so safe and so free of toxicity that we can use it with anybody at any age.
Thank you, doctor. The second question is coming from Dr. Wael Omar. In your presentation, the best result to have combination with 2% niacinamide. So is this combination has this maximum result rather than tranexamic acid 2% alone?
No, I think it's difficult to give you the reply, you know, from the paper itself because there was no comparative study. But in terms of pharmacology, the mechanism of action of tranexamic acid and niacinamide on hyperpigmentation is different. So we can imagine that the combination of both is more efficient than each one separately. But there is no scientific publication about this. Maybe it could be interesting to do it. And in the same way, you know, we talked about the best concentration for topical tranexamic acid, it's 3%, but we didn't talk about the best concentration for topical niacinamide. And in Italy, especially, we are using concentrations of 4 or 5% with lot of success, you know, and a lot of efficacy and no side effect. You can use 2% or 5% niacinamide in topical. The number of side effects is similar. So maybe it would be good using a higher level of niacinamide. If you have it on the market, I recommend 4 or 5%.
Thank you, Doctor. Another question coming from Dr. Hudaifa Akarawi. What about the recurrence rate with tranexamic acid? Is it the same as others?
Yes, doctor. Regretfully, it's the same as others because when we discontinue the treatment, step by step, the recurrence will occur, of course, as for any treatment for melasma. But the good thing is that with tranexamic acid, you cannot do it with hydroquinone because of the side effects and so on. But with tranexamic acid, you can have maintenance treatment, you know, once per day or once every 2 days, and you can avoid and prevent this recurrence.
Thank you. Another question coming from Dr. Ahmed Saad. What is the other indication of topical and systemic tranexamic acid in dermatology? Well,
I told you maybe briefly, but besides melasma, which is really the major indication, the second one may be erythematotelangiectasic rosacea, inflammatory rosacea, and telangiectasia more globally, and also, as we saw it, post-acne erythema looks to be a very good indication. But you can be sure about something. We are in the first period, you know, of rediscovery of tranexamic acid in dermatology. And I am sure that it can be useful in many other indications. We have to investigate it and to check it. And I know that dermatologists are very curious, you know, and are really scientific oriented, and they try to catch new indications and based on their experience and so on. But I am sure that in 5 years' time, we'll talk about a lot more indications.
Thank you. We have another question coming from Dr. Remy Strabier. Can we prescribe hydroquinone and tranexamic acid together at night for melasma?
Yes, you can do it, doctor. This is a very good solution and combination. You know, you remember we saw it in the studies, in the papers. This is an excellent combination, but in this case, use tranexamic acid twice a day, morning and night, and at night, combination of tranexamic acid and hydroquinone.
Okay. We have another question coming from Dr. Aya Alaitan. First, he or she would like to thank you for this interesting presentation. And he's wondering, do you have any input about combining tranexamic acid with glutathione in microneedling?
No, I don't have it. I can tell you it doesn't exist in the literature. You know, there is no published data about this. And personally, I didn't do it because in Europe, we don't use a lot glutathione. You know, it's more, let's tell, Asian practice. You know, glutathione is much more used in the Middle East and Asia than in Europe. So I have no personal experience, but I think always thinking about mechanism of action, you know, mechanism of action is completely different between both products. And I think this is an interesting possibility and interesting alternative. You should try it because there is, of course, obviously no danger to do it. And this could give good results. Good idea.
Okay. Thank you very much for your answer, Dr. Diehl. I think we have no more question for the time being, except if somebody has something to ask regarding the presentation which has been done during 1 hour. For the time being, there is no other questions. So, well, maybe we got one more question coming from Dr. Tikra Hussein. Is there any study regarding the way to use for macular amyloidosis?
I don't think so. I never saw it, at least.
Okay, so no studies about that. All right. Do you have any question? Any other question for Dr. Christian Diehl? Just before letting you enjoying the weekend, because we are Thursday night, and probably most of you you have a day off tomorrow because we are Friday. So let's have a look on the questions. Yes, we do have. One question that coming from Dr. Alak Al-Ghurabi another time. Is it safe for children? I would say yes.
Yes, it is, doctor. No, absolutely no risk about it.
Okay, another question coming again from Dr. Aya Aleikan. There is a preparation from MD Cuticles combining both. Is it a British company?
Which company? Can you repeat?
MD Cuticles. MD Cuticles.
I don't know so much about industry, you know, but I think that MD is maybe a US company, maybe American company, more likely.
Yeah, okay. All right. Another question coming from Dr. Hudaifa Karawi. It was a great presentation. Thank you very much, doctor. Tranexamic acid, sorry, is not photolabile.
Is not, sorry?
Photolabile.
No, it is not. No.
Okay. Another question coming from Dr. Tikra Hussein. What about the combination with chemical peeling?
Honestly speaking, I didn't see any publication about this, you know. I didn't do it too, but I think it can be a good combination. And all the more because, as I told you, topical tranexamic acid is very safe, you know. It is not aggressive, and we talk about tranexamic acid, but the solution is not acidic. It's almost neutral, you know. And don't think about aggressive acids, you know, like trichloroacetic or glycolic or salicylic or something like this. And for this reason, combining tranexamic acid, topical tranexamic acid with peeling could be a very good solution. Yeah, it could be a very good combination. But I didn't see anything published about it.
Okay, thank you, Dr. Diehl. Just in between two questions, I would like to tell you that some doctors are thanking you about the presentation, which was really interesting. So this is not really a question, but it is just a confirmation that your presentation, doctor, was really interesting. Dr. Black, Dr. Zeina, etc. We got a question coming from Dr. Abdul Malik. I don't know which country you are from, but he's asking, is it costly we are really taking care about the price, so we don't want to make the product expensive. So it is probably affordable in your country, but I don't know which country you are coming from and so on. So this is maybe you can send us a message in the mail of the company, and then we will keep you in touch with our local distributor in your country. We have last question, another question coming from Dr. Enas Sarif. Can we give alpha-arbutin with tranexamic acid?
Yes, absolutely. There is no contraindication, you know, and this can be once again another good combination, because the mechanism of action of arbutin, you know, is different. It's by blocking tyrosinase, and it's completely different from tranexamic. So it can be a good combination. Yeah, more complete combination and more efficacy.
Thanks. Another question coming from Dr. Alak Al-Ghurabi again. If there is a sensitivity from using the product, what is the step should we do? I mean, what can we do if there is problem of sensitivity?
Well, doctor, honestly, sincerely, I never was in this situation, but I think we could remedy with topical corticoid, quite weak topical corticosteroid, and this would be the solution. But really, don't be afraid about it, because we have a spectacular tolerance, skin tolerance of the product.
Another question from Dr. Tikra Hussein. Any reports about photosensibility with tranexamic acid?
No, this is a very good question, doctor, and thank you, because I forgot to talk about this. And really, we made studies, of course, about this, and tranexamic acid is not photosensitive.
Okay, perfect. Thank you very much, Dr. Diehl. I think that we have, I mean, everything has been answered. We have no more question for the time being. So I would say that we have to thank you once again, Dr. Christian Diehl, because it was really interesting, and thank you for your time. I would like to thank also all the doctors attending the meeting for this afternoon, and maybe especially if there are some doctors from Kuwait, because I know that today, the 25th of February, is a national day in Kuwait. So I would like to thank all the doctors attending the meeting, and especially the ones coming from Kuwait as well. Thank you very much for your attention, and please don't hesitate to come to the connection you can find in the presentation in order to get some more information about the products and the presentation of today. Thank you very much, Dr. Diehl.
Thank you. Bye-bye.
And thank you, and I hope to see you soon. And thank you, everybody.
Thank you. Bye.